Welcome to today's MESUD Learning Community Echoes, Substance Use Disorders Through a Pharmacy Lens. Today we'll be hearing from Stephanie Nichols on overdose prevention. My name is Bethany with CCSME and I'll be supporting today's webinar. Just a few quick notes before we begin. First, neither the presenters nor the planners have any relevant financial relationships to disclose. This activity has been approved by the Maine Board of Pharmacy for 1 hour of continuing education credit. This activity has been planned and implemented in accordance with accreditation requirements and policies of the ACCME through a joint proprietorship of the Hanley Center for Health Leadership and Education and CCSME. The Hanley Center is accredited by the MMA Committee on Continuing Medical Education and Accreditation to provide CME for physicians. The Hanley Center has designated this activity for 1 AMA PRA Category 1 credit. Recording and live stream transmission of this webinar without consent is not permitted. And with that, I will hand it off to Stephanie for our presentation. Thank you all for being here today.
Thank you so much, Bethany. And it's great to see you all here today. And I'm going to build on the presentations we've had so far in this Echo series and talk about overdose prevention and naloxone. And I do want to acknowledge that some of these slides came from a presentation that very own Whitney Jandrew and I did together at the Maine Pharmacy Association, Maine Society of Health System Pharmacists meeting a couple of years ago, I believe, give or take a couple of years there. So here we are, and I'm glad that Whitney's here as well. So please correct me if I missed anything or got anything a little off there, Whitney or anyone else in the room. So overdose prevention, talking about naloxone and a few other things. And I have no disclosures or conflicts of interest related to this content other than I'm pretty passionate about this. In particular, I'm passionate about things like word selection. And so I'd remind us all that words are important. And so if we care for something, we call it a flower. But if we want to kill it, we call it a weed. And we can think about flowers like dandelions and roses to help us remember that concept. So words are really, really important, both when we're talking about flowers or weeds, but also when we're talking about humans. So now let's talk about overdoses and specifically opioid overdoses. And I thought it would be really important to start here with us as particularly a pharmacy community to think about what our risk factors are for opioid overdose. And this is opioid overdose for any reason. So this is in people who have opioid use disorder as well as in people who do not have opioid use disorder. So the number one most important risk factor for opioid overdose is dependence on opioids. So that's this physiologic dependence on opioids at the receptor level. And then particularly when that is present, and then a patient has a situation of reduced tolerance. So this could be, looking to the right-hand side of that blue box there, this could be a situation where someone has gone through like acute detoxification from opioids, but is not then started on any kind of opioid therapy that would provide agonism, so like buprenorphine or methadone, for example, or another opioid in other countries that they would use for opioid use disorder. Another example would be after release from incarceration or hospitalization. So after release from incarceration, oftentimes, unless a patient has continued on their MOUD or started on new MOUD, the patient will have lost any tolerance they had, a very high risk situation for an overdose, or hospitalization, same thing. Although often in the hospital, patients are given acute opioid therapy for whatever reason brought them into the hospital, surgical needs or other painful conditions. But this would also apply if a patient did not get opioids during that hospitalization for whatever reason. And then finally, after cessation of medication for opioid use disorder and the loss again of tolerance. So this again would be specifically with the loss of tolerance after a cessation of buprenorphine or methadone, or in a patient who's been receiving naltrexone, particularly long-acting injectable naltrexone as an opioid antagonist, and then stops receiving that MOUD because that person also has no tolerance anymore, being on that antagonist for a period of time. Other risk factors include things like use of prescription opioids, and we know this is a dose-dependent risk, so we know that the curve really starts to separate between those that are on 1 morphine milligram equivalent and those that are on 50 or more morphine milligram equivalents at about 50, and we know that curve continues to separate as that morphine milligram equivalent dose goes up. So increased risk at 100 morphine milligram equivalents, at 200, and on and on. And we have some homegrown data here in Maine that shows direct link between prescribed dose of opioids based on PMP data and opioid mortality toxicology, postmortem toxicology information. Another risk factor is non-prescribed use of opioids. So, anyone who's using opioids in a non-prescribed fashion, but also anyone who's using any other substances in a non-prescribed fashion, particularly anything that is available in like a pill, like tablet or capsule form, because we know counterfeit tablets are very ubiquitous. People press what are benzos, but they're not really benzodiazepines, or maybe they're benzodiazepines that are available in other countries or not available in any country, but sort of research chemicals. They're often mixed with fentanyl, so people can have an opioid overdose with the use of just benzodiazepines or just even like pressed Adderall. Same thing, maybe has some stimulant in it, but also has fentanyl. So anyone who's using any non-prescribed substance, especially tablets or capsules, is at risk for an opioid overdose in 2025, and so should have take-home naloxone. Other risk factors include the use of opioids with any other sedating medications, but specifically and more so CNS depressants, and specifically and more so those that impact respiratory drive. So those that impact central respiratory drive. So the most important ones there, in addition to additional mu agonists, would be things that agonize our GABAergic receptors. So those would be GABAergic drugs like benzodiazepines, barbiturates, other sedatives, are Z GABAergic drugs, those benzodiazepine receptor agonists like zolpidem, for example. We can't forget about carisoprodol in particular, being our GABAergic muscle relaxant. And alcohol also is a GABAergic medication or substance, in addition to having other pharmacology. Also, use of opioids in patients with certain medical conditions. So any medical condition that's going to increase the concentration of that opioid, maybe because the person has drug interactions at play. Maybe they're getting a 2D6 inhibiting medication that's bumping the levels of that 2D6 substrate, like hydrocodone. Is a 2D6 substrate and a 3A4 substrate. Or maybe they're getting a 3A4 inhibitor, or maybe both. Maybe they have liver dysfunction or renal dysfunction. And so the elimination or metabolic process of the opioid is no longer happening. And so the concentrations are higher. In people that are more susceptible to respiratory depression from a disease perspective, because maybe they have COPD or sleep apnea. Asthma doesn't seem to be as much linked to this. Certainly it's something to consider, but most important here would be the history of COPD or sleep apnea. And then also people who are at increased risk of suicidal ideation. So we know there are a whole host of people that are at increased risk of suicidality. But in particular, I want to call out people with mood disorders and then certainly depressive disorders, but even more specifically, bipolar disorder. We know that upwards of 15 to 20% of people with bipolar disorder do die by suicide, and up to 60% of people with bipolar disorder have a suicide attempt. So this can't be underscored enough. And then finally, people have access to opioids in the home that are not the patient. So these could be adult people that have access to opioids. These could be strangers or friends or family. These could be children or adolescents. And these could also be non-human people, non-human beings like dogs or cats or others. So a lot of risk factors to consider and a lot of opportunity for us as pharmacists to make recommendations in education. So we love rating scores. So there's this risk index that exists for prescription opioids, and you can see the cutoff here on the left-hand side. If the score is less than 3, there's a very low predictive probability, only 3%, that a person will have an opioid overdose. But once the score reaches 67, the risk of a patient having an opioid overdose is 94%. And so you can see that there's a clear sort of risk cutoff on the lower end and the higher end. So what makes up the greatest points in this risk scoring? So what's like the most important here? It's what we talked about right at the very beginning, the dose. The dose that the person's prescribed is the most important thing. And so in this scoring, if someone is on 100 morphine milligram equivalents per day or more, they have a score of 16 just from that alone. 50 to less than 100, a score of 9, and 20 to less than 50 is still a score of 5. The other factor that makes up the second highest point value here would be if someone has been to the emergency department in the past 6 months. And so that would be another major risk factor according to this risk assessment. So let's talk about what's going on toxicologically and pathophysiologically, but not too deep. I did, for those that love to kind of get really deep, I do have a lovely picture for you, and it's talking about your intracellular cyclic AMP and a whole bunch of other things that you might be excited about. But for those that don't want to get sort of that deep, you just want to focus on this green arrow here that's pointing to opioids impacting this opioid receptor. So basically, we want to remember opioids are mu agonists. They cause the central respiratory depression, the central respiratory suppression, particularly in overdose. And so more specifically, they're blocking the CO2 chemoreceptors in the medulla. So they're blocking these chemoreceptors. And so that's why patients are not feeling in distress when they're having an opioid overdose, because those chemoreceptors are not saying like, hey, there's a lot of CO2 here. We're retaining a lot of CO2, we need to breathe. This is just not happening because of this central respiratory suppression. So it's really important to tell patients that the opioids cause the brain to stop the person from trying to breathe in a poisoning situation. And this starts by the person slowing their breath down, by having this sort of central process of just breathing, less breaths per minute. And so it's really important to educate people that to not watch for someone gasping for air or even appearing in discomfort as an indicator of an opioid overdose. That's not the way this works. It's a central process in the brain. And so we'll talk about what we want to look for instead. But before we get there, we need to talk about the other side, which is how do we handle this? So as we all know, because we're here, naloxone exists, and it's super, super important in our treatment of people with opioid use disorder, particularly in the treatment of an acute opioid overdose. It's a very specific high affinity opioid antagonist, so it generally has a higher affinity than most other opioids, which means that the receptor will preferentially bind with it rather than the other opioid. And that means that if there's another opioid there, like heroin, it will actually kick that other opioid off the receptor and bind to it instead, reversing that overdose. Side note, buprenorphine has a higher affinity for the opioid receptor, so naloxone does have a more difficult time kicking buprenorphine off of the opioid receptor, but that is actually less concerning because buprenorphine is a partial agonist, and so the risk of opioid overdose with that medication is lower inherently. Back to naloxone. So naloxone only works. It works on that mu opioid receptor, and it just sits there. It doesn't do anything on its own. It just doesn't allow opioids to bind to it, and will kick opioids off and bind itself if they're there. So it only works if opioids are involved. It's not going to work on any non-opioid based substance, and it's not going to harm someone if it's given in someone who has no opioids in their system. So what does this mean? If there's another substance on board, naloxone is not going to help. But also remember that opioids are in a whole bunch of other things. And so we should probably give the naloxone anyways, because there might be a component of an opioid overdose at play. And then B, it's not going to hurt the person if we do give it anyways, and there's not an opioid component at play. It's not going to harm the person at all if there are no opioids in the system. So how do we know if someone's having an acute opioid overdose? So we can think about this mnemonic and really think about blue. Blue is going to be one of our keys here. So we're going to dive into why is it blue? We're going to jump into lips, and then we'll go back. So why is the mnemonic blue? Blue is what we can think about when we think about loss of oxygenation, because once we stop oxygenating our tissues, some of our peripheral sort of endpoints start to turn blue, things like our lips and our fingertips, things that our body prioritizes lower as far as sort of like oxygen and blood perfusion and oxygenation. So we want to look for blue lips or fingertips, or maybe gray lips or fingertips. And some of this discoloration might vary a little bit depending on a person's underlying skin tone. So it might not look exactly blue, but if a patient skin looks gray or ashen, that's a strong indicator, especially if they also have breathing that is either slow, shallow, erratic, or absent. Occasionally, there might be gurgling breathing as well, particularly if there's like a polysubstance overdose situation. But what we're really looking for pure opioid overdose is that slow, shallow, and then absent breathing, right? So that really slow, shallow respiration, because the brain's not saying, hey, we need to breathe, we need to breathe, we need to breathe. We also find that patients are often non-responsive to verbal or physical stimulation, so the U is unresponsive. And then finally, with opioids, we know opioids cause constriction of pupils or pinpoint pupils. We see that in the eyes, but I really want to stress here that while this is part of our opioid overdose mnemonic, and this helps us to understand if opioids are at play, pinpoint pupils by themselves do not indicate an opioid overdose. If any of us took a single dose of opioids right now, a therapeutic single dose, we would have pinpoint pupils. That's what opioids do. That is not indicating the person's having an opioid overdose, but it can help us to differentiate if someone's found down and we have no idea if we're looking at opioids or not. All of that said, we are in the middle of an opioid epidemic and opioid overdose rates are high. So often we don't even think about pupils when we're thinking about our response because we're going to err on giving naloxone if it's even a possibility of helping because it will not hurt. So that brings us to our steps in an opioid overdose. So we want to try to arouse the person. We can call their name if we know their name. If we don't, we can say, hey, are you okay? They might be sleeping. If they don't respond when we try to arouse them, then we can try to elicit some physical stimulation. One way to do sort of like more mild painful stimuli is a sternal rub. So kind of put a knuckle out and rub the sternum. Another way is to compress the nail beds, which provides a little bit more physical stimulation and some pain, and which a person who is in an opioid overdose will not respond to. If a person does not respond to arousal, then you want to assess if the person's breathing and has a pulse. You also at the same time or right after that, depending on if you're alone or have other people with you, want to call 911. If there are other people with you, it's important not to just yell out, somebody call 911 because you get the scarecrow, right? So you want to make sure that you say like, hey, you call 911. Hey, you go grab another dose of naloxone in case we need it. And hey, you go grab the AED just in case we need that too. If an opioid overdose is suspected right after you've called 911, that's when you want to administer naloxone. But if there are multiple people there and you have the naloxone ready to go, someone can call 911 and someone could be administering it at the same time. It is important to note the time administered. So if you call 911 right as you're administering it, your phone then will track what time it was administered. And that can be really, really helpful because you need to know to repeat in 2 to 5 minutes if the patient hasn't responded. Generally, especially for the second repeat dose, you might consider repeating in more in the 2 to 3 minute mark rather than waiting out to the 5 minutes. But then after sort of the second dose, generally the 2 to 5 minute mark. And then if it's indicated, if someone does not have a pulse and the skills are available, then CPR can be performed. Rescue breathing could be indicated in the meantime after naloxone is administered while waiting for a response, or if a patient is not responding and you don't have more naloxone available. CPR with the compressions would only be indicated if a person does not have a pulse. Once you're waiting for the naloxone to start working, you want to turn the person to the recovery position. And the reason for that is because if the person does vomit, which we know can happen with an acute opioid withdrawal, which can occur with naloxone administration, then the person's vomit goes out of the body and onto the ground or a receptacle, but does not go into the lungs, which is, another very risky situation with aspiration pneumonia and even just aspiration pneumonitis. And then we always want to stay with the person until EMS arrives. So this is sort of an algorithm. It's mostly the same things. This is a little bit more focused on opioid poisoning. So this kind of prioritizes giving naloxone before checking a pulse. And I think there's a few different ways you can do this. I think this is entirely appropriate too, particularly if it's more risk that the person is having a direct opioid poisoning rather than more uncertainty whether it's cardiac arrest or opioid poisoning, would be to call 911 still, but then open that airway and give naloxone first and then check that pulse. And then again, if the pulse is present, we do not do CPR, we do the rescue breathing. We want to repeat the naloxone every 2 to 5 minutes until the patient has a response, and we're going to continue to wait until they're transported by EMS. And if the pulse isn't present, then we start the CPR, and then we can pause the CPR to administer naloxone. So if we gave the first dose of naloxone before checking the pulse, and then we identify the pulse is absent, then we would start CPR at that point, and then we could pause the CPR in the 2 to 5 minutes to give another dose. If we check the pulse first and identify the pulse is absent before giving naloxone, then we would do a round of CPR and then give the naloxone. Because the heart has stopped at that point, and resumption of respiration is not going to help if someone's heart is not beating again. So it depends on where in the process they are. Opioid overdose first stops breathing, but then when breathing is stopped long enough, when oxygenation is not happening long enough, then the heart will stop. So that's kind of the natural process. I would be remiss if I didn't mention xylazine. As of the most recent data I found a couple of months ago, up to 10, 11% of fatal overdoses here in Maine were related to xylazine and fentanyl. And you might be thinking, what is xylazine? Or you might be thinking, ooh, I've heard about this before. Either way, we'll bring us all up on the same page here. So xylazine is a substance, it's a veterinary tranquilizer, and it's generally cut into heroin, which is actually fentanyl, and a lot of other substances, but often opioids. Xylazine is an alpha-2 agonist, like clonidine actually, but it's different than clonidine. It causes a lot more sedation, really profound sedation, and also it has some kappa opioid agonism properties that may contribute to part of the wounds that we see with xylazine. So these really profound wounds, sometimes down to the bone and sometimes not in the area of injection itself. What's important for us as pharmacists and as opioid overdose response educators is that xylazine will not respond to naloxone. Naloxone is not an alpha-2 antagonist, right? So it's not going to do the opposite of xylazine. Naloxone only works on those mu opioid receptors. And so a patient may continue to be passed out from the xylazine after they've had a resumption of their breathing from the naloxone administration. So if a person has resumed breathing, then the opioid receptors are no longer saturated. And so we do not need to continue to give more naloxone. The caveat to that is we have to watch for those longer half-life opioids like methadone and others that will outlast the half-life of naloxone. This is really important because when we think about our acute endpoint for naloxone, our acute endpoint is a resumption of breathing. We don't want to put people into an acute overdose, we don't want to put people into an acute withdrawal situation. Sometimes that happens and it's sort of something that we accept as one of the risks, but it's not our goal at all. And so our goal is resumption of breathing. And so if a person is breathing after naloxone administration, even if they're still passed out, and as long as EMS is already on the way because you've already called them, then just continue to support that patient. It might very well be xylazine on board. If the patient starts to have slowed and stopped respirations again, then of course, administer another dose. I also would be remiss if I didn't talk about safe medication storage. So medications, especially opioids, should be locked and stored in a place away from children, pets, and also others as well. And unused opioids should be disposed of when they're no longer indicated. So there are most, if not all, police stations will take back opioids, no questions asked, or take back any medicines, no questions asked. Many pharmacies now and by law have take back receptacles within pharmacies themselves, but outside of the employee only area, sort of where patients can just go up and dispose of substances twice a year. The DEA holds take back days, so they're often held in multiple locations here in Maine, usually in October and actually I think this month around April or so, or March maybe. And then also this is where the organizations differ a little. The DEA says do not dispose of opioids in toilets. The FDA differs and says opioids in toilets are okay if there's no other method available. And the FDA says that coming from the perspective of not having opioids around that could potentially poison people and sort of the total risk versus benefit. So if all is said and done and a patient has no other way to dispose of opioids, a toilet method is okay according to the FDA, but we do know that it can have environmental impacts. And so that's one of the concerns the DEA has brought forward. So other disposal options are preferred. For naloxone, there are multiple formulations of take-home naloxone, but one of them is no longer available. This third one, the auto-injector, the Evzio that used to talk to people, that's no longer made anymore. So really we're down to three. We're down to the traditional one that was available in hospitals and is still available to this day, the vial and the Carpuject. We've got the modified product that came about before we had FDA-approved take-home formulations, and this is a modification of the Carpuject to allow for nasal administration with a nasal adapter. And then we've got the now FDA-approved nasal sprays, and the Narcan NS was the first one with the 4 milligrams, and now we have a higher dose and a lower dose formulation as well. And beyond the scope of today, because I didn't want to get into the nitty-gritty of the prescribing information, but I wanted you to have that. So there's a link here to Prescribe to Prevent that has all that information available for you. But these are really the two big ones that we use for take-home naloxone these days. So on the left-hand side is the Narcan NS, the 4 milligram. It's really simple. We instruct patients. So this is a very well-used naloxone, Narcan NS, because I carry it with me. But this is what it looks like. So people peel it back. So you just peel it back. There's a single device within this package right here. Each Narcan NS box contains 2 of these. There's 2 doses. This single thing is 1 dose. The person takes this thing once they've opened it up. They put their fingers on the either side of the plunger, not on the red part, not on the actual plunger itself, because once the plunger is depressed, the dose is gone, whether it was in the nose or not in the nose. So on either side, just so there's not an accidental depression, and then, fingers on either side of the top part, and then thumb on either one side or the other of the bottom part that's not the red part. Put the device into the person's nose far enough so that the bottom of their nose is touching the top of your finger, or whoever is administering the medication's finger. Put it in, and then when you're ready to go, put the thumb on that red part to depress the plunger. Give it 1 firm plunge, squeeze, and that is 1 dose, 1 nair, done. And then we would repeat with the different one, the second dose in the box. So a different container completely. This one's done. We can just throw it to the side. A second dose if we need in 2 to 5 minutes. If it is a situation where someone's using the adapter, it's a little bit more complicated, but you can see the steps here. Basically, they have to take the yellow portions of the adapter off, the top and the bottom, and screw on, instead of screwing on a needle, they would screw on this nasal adapter, which allows for nasal administration. And then where the needle, you can see inside the carpuject there, that line is the needle. So that needle, then they would put the carpuject inside, put the vial, inside the carpuject, which would pierce the vial and then allow the medication to be released, go through that nasal adapter and into the nose. So that's how it's kind of screwed on. And then the other difference with this one that's important to educate patients about if they're using this is that half of the medication goes in one side and half in the other. So this 1 syringe is 1 dose, but half goes in one side and half goes in the other. And that's different than the FDA approved form where it's just in one dose, one push, one side of the nose, 1 nair. Okay, a couple of other small things that I just want to talk about. They're not small, but I think they're maybe a little bit more sort of side notes, but important nonetheless, is that stigma is still a major barrier here with naloxone. And so reducing that stigma by universally offering naloxone to all high-risk patients is a really important first step. So at your pharmacy, you might decide that all patients who are on opioid doses of at least 50 morphine milligram equivalents and all patients who are on opioids and benzodiazepines, barbiturates, or crisaborole, and all patients with an opioid use disorder, and all patients with a history of overdose, and all patients who use opioids and have major depressive disorder or bipolar disorder might be offered naloxone. Or you could pick some of those, right? But those are things we know that increase the risk of opioid overdose. And by doing this, by offering it in this way, then you remove any thoughts a patient has about, like, why was this offered to just me? Or what does my provider think about me? And especially in people who don't have an opioid use disorder, sometimes that can crop up again as a manifestation of stigma. So if you can say, this is something we do for everyone who's on an opioid dose of at least 50 morphine milligram equivalents, then that alleviates that. You want to discuss why naloxone is indicated in patients who don't think they need it. So kind of talking about the risks of opioid overdose and why they're at risk, but also comparing to other things. So other harm reduction strategies, and we learned about that last week, but also other medication adverse effects like constipation, for example, with opioids. And then also, and I think someone mentioned this last week as well, talking about other people. So other people might have access to the opioids and could have a fatal overdose. Talking about naloxone, normalizing the conversation, doing everything we can to break down barriers. So if we can create cards in the waiting room that say something like, I want naloxone, and then someone can literally just bring it up to you and bring it to the counter and give it to you, and you can have a sale without even having to maybe have a conversation, that could remove a barrier for someone that's maybe really nervous about how that conversation would go. So simple things can make a huge difference here. And you want to educate everyone in the pharmacy, everyone in the office, everyone, that first person that's going to pick up the phone or be cashing a person out of the cash register about stigma and how that impacts people and their ability to ask for help with opioid overdose education as well as naloxone and more. and advocate. There's so much we could say about this, but I'm going to not in the interest of time and leave us with this, which is the opposite of addiction is connection, and tough love doesn't work. Time, affirmation, care, and supportive love do work. And we need to keep people alive through this non-linear process into recovery, and naloxone can help us do that. And so I want you to prescribe naloxone.